Thanks, everybody. It's a great honor to be here. As Muad mentioned, I'm going to be zooming out a little bit today, but it still should sort of be in context of yesterday. So in the past, 10, 15 years, and I assume the perspective that maybe a lot of you have, either preclinical or maybe in the perspective of using psychedelics as a treatment in psychiatry for affective disorders, this kind of thing. But what about in neurology? Where might psychedelics have an application here? It's not about trying to shoehorn something in, but I think by the end of this talk, hopefully you might have a little bit of an idea of what I'm trying to get at. And specifically, there's been a little bit of noise in this space, and specifically I'm going to be talking about disorders of consciousness. So what are disorders of consciousness? Maybe some of you don't quite know. So there are a range of disorders that somebody might enter following a severe brain injury. So severe brain injury can come from things like stroke or heart attack or a car crash, a traumatic brain injury. A patient can enter a coma. A coma is a sort of transient state that lasts anywhere from a few hours to a few weeks. After that, patients can enter the range of these different states. The two ones that are important to sort of talk about, I'll get this laser working, is this unresponsive wakefulness syndrome, also known as the vegetative state, which is essentially where patients can have their eyes open, but there's no signs of consciousness. There's signs of wakefulness, but no signs of awareness. Whereas there's also the minimally conscious state, where there is, again, eyes open, there's wakefulness, but then there's different signs of consciousness that might be present in that patient, which then you can separate into the minimally conscious state plus, which is the preservation of language capacities so they can respond to command, or the minimally conscious state minus, where they have not language capacities, but they have these sort of lower level signs of consciousness like visual pursuit and that sort of thing. So really, just to say that it's a range of disorders with different kinds of expressions. So how might you then sort of map the brain dynamics of different states and disorders of consciousness into some kind of map, I suppose. Now, Chris touched on this yesterday. It's kind of the same sort of thing that he showed, a little bit expanded upon. So you've got this idea that, well, ordinary waking consciousness sort of occupies this state that's close to the critical point, criticality. So what is criticality? It's the transition point between order and disorder. And at the critical point, there's a bunch of sort of important properties that characterize this point, or zone, rather. There's a few here, the kind of. Today we're going to be focusing on this. Today we're going to be focusing on this sort of high sensitivity to perturbations. But essentially, at this critical zone, you have a high complexity and many of these points. So we can think about disorders of consciousness as existing in this sort of like low entropy, low complexity, subcritical zone. And again, like maybe the psychedelic state is a little bit up here. I know there was a little bit of talk yesterday about maybe being subcritical. I'm still getting my head around that, looking at the methods of that paper. But this is the general idea. So then what we can think about is disorders of consciousness are a group of pathological disorders with a low complexity, a distance in the subcritical zone. Whereas the psychedelic drugs are a sort of transient agent that can push a patient in a disorder of consciousness towards this sort of this critical point, and maybe towards ordinary waking consciousness. So we can think about it in a different way to kind of what we've been thinking about as psychedelics in affective disorders, where we're really looking at the acute effects of the drug. During the acute effects of the drug, if complexity increases and that's associated with consciousness, would we have new conscious behaviors? That's essentially the idea. So, but then we've got to think about, well, these patients have massive structural damage. This is just some examples of some diffusion images of different patients. So that sort of distribution I showed you before, you can think of as like the possible distributions of states for somebody that's healthy, with a healthy structure. But then perhaps in these sort of disorders of consciousness, maybe the actual distribution of possible states changes because of the underlying structure. So what I'm sort of encouraging is, even before we talk about the science itself, let's try to think about like what might happen if we were to give a psychedelic to somebody in a disorder of consciousness. I see two different kind of scenarios. Scenario one here is we can give these patients a psychedelic, and it pushes their dynamics closer to the critical point, and they're following this healthy distribution, and their cognition, their sort of cognitive capacities are increasing. Maybe they can respond to command or something like that. Or maybe we should also consider scenario two, which is the underlying structure has changed. So what actually might be happening is before the psychedelic, they're already at the sort of optimal working point for their structure. And after you give them a psychedelic, you could perhaps have this sort of decrease in the cognitive capacities. We don't really know, but it's important to consider these different kinds of scenarios. So that sort of begs the question of what really is a good outcome. So there's limited treatments for all patients in disorders of consciousness. So any kind of thing that would increase, the likelihood of somebody being able to communicate with their family member or something like that would be, really valuable. What if there was some sort of like increase of awareness, but again, the cognitive capacities decreased, so they couldn't respond to command or something like that? Is any increase in conscious experience, awareness, whatever, is that nevertheless a good outcome? I don't really know. I mean, maybe it's a personal preference. You could imagine what you might want in that sort of position. So we can think about doing the science. So obviously, this is quite difficult to do experimentally. So we consider, what about using computational models? So computational models can be sort of ethical precursors to do difficult things. What I use is these whole brain models. Essentially, how they work is you have some empirical structure, some empirical function, and then you have some underlying whole brain model with different local dynamics, and we'll talk about those in a second. And you can simulate some bold time series, which is at some kind of target state. So what you can do is you can actually do this for each individual patient to have these sort of personalized models. And then with this personalized model, you can map each patient. You can sort of create a way to assess the dynamics of the simulated data. Then you need a way to simulate the drug. Then you can run this sort of like virtual clinical trial, right? Once you then apply the drug, then you can look at sort of how a patient might respond, and then this might enable you to identify candidates to put forward to actually doing this sort of trial in real life. So a little bit more details on how these kind of models work that I use. So I use these hop fold brain models, basically based on Stewart-Landau oscillators. So essentially how it works is that the brain's split into a number of nodes, and each node is represented by this differential equation. And this is just essentially an oscillator that looks a little bit like a Bold signal. There's a free parameter, this alpha, which is the most important. In the negative values, it sort of goes down to a fixed point, whereas in the positive values, it's like it goes to a limit cycle. So it has this sort of like two regimes of behavior, and at zero, it's at like a critical point between these two regimes. So with this alpha, you can then optimize the local parameters to fit your empirical functional connectivity. So this will be from the patient. And then you have this, essentially, this functional connectivity, which is optimized towards the individual patient. And the way that we can assess the dynamics might be to simulate a perturbation. And we can say then, does the perturbation sort of index the level of consciousness? Let's just touch 2 seconds on how this perturbation works. Essentially, it's based on phase. You have a phase coherence matrix. You can binarize this over different thresholds, and then you can look at the largest connected components at each time point. You can plot this so you end up basically with an integration value, and then this alpha parameter again, what you can do is you can set it to a certain value to sort of put stability into the model, and that acts as a perturbation, which then over time and over many trials, you can see how the system overall responds to a perturbation. So this is allowing you to assess the dynamics. We call this the PILI, basically. So what we found is that we sort of make these models on these different states, like anesthesia, propofol and dexmedetomidine. You've already seen these disorders of consciousness, and LSD and psilocybin. And what we could see is that sort of in these like disorders of consciousness, the response to perturbation decreased, whereas in these sort of psychedelic states, it's actually a little bit higher than the control, the placebo. So how do we simulate the drug? Well, okay, what we don't have is a patient with a psychedelic drug, right? So we have to make certain assumptions. So the way that we can do it is what we do have is a psychedelic data on healthy controls. So we can build a model based on the placebo and based on the psychedelic, and then we can extract the change in the parameters in these models and then apply it to the patient models to essentially simulate a patient with a psychedelic. There's a big assumption here. You're essentially assuming that the psychedelic will act the same on the patients as it does on the controls, which is obviously a massive assumption. But in the absence of actual real data of patients with a psychedelic, it's you know, a workaround that we can do in the meantime. So what we found is that simulating this LSD and psilocybin on each patient, so each of these blue circles is a patient model, and then the red diamonds is LSD and the green diamonds is psilocybin, increases the response to perturbation of these patients. And the effect of psilocybin was a little bit higher than the effect of LSD. And then looking at these regional sort of changes, the response to perturbation, what we could see is that actually the response to perturbation in the UWS patients, the networks with the largest changes were the sensory motor, whereas in the MCS patients, you had all these higher order networks. So that's maybe suggesting a little bit about what the effects on consciousness might be. I mean, a massive increase in the sensory motor network might not result in changes in consciousness experience. It would be less likely to, perhaps. So then you can ask yourself, okay, so can we then look back in the baseline real data of the patients and then predict how they might respond to the treatment? So look for like a biomarker of potential treatment. And what we could see is actually in the UDS group, it was the structure which was correlated more with the treatment effect, whereas in the MCS group, it was the function. So we have this idea that in the MCS group, it's really the idea that the structure is no longer a limiting factor, and it's really the functional connectivity which is driving the treatment effect. So take-home messages are a model perturbation can distinguish between states of consciousness. Then we ran this virtual clinical trial, and we can push the dynamics of patients' brains closer to criticality, and the treatment effect is correlated with the structure in the UBS group and the function in the MCS group. So as like a patient that we can push forward, as this is the ideal patient to test this treatment on, it would be an MCS patient with a high functional connectivity, essentially. So then I'd just quickly like to touch on this, which is the work of my colleague, which was a case in which in Colorado there was a doctor and his wife ended up in a disorder of consciousness, in a minimally conscious state. And he was not only the husband, but the primary caregiver, the doctor. So she was an experienced user of psychedelics, and he read about our work, so he contacted us to see if we would be open to doing an observational study where he administered her psychedelic, some psilocybin. So we looked at the EEG measures with LEM-positive complexity, which significantly increased, some relative power. We had decreases in these low power bands, but we had some increases in these beta and gamma, but no change in alpha. But most interestingly, the behavioral results, so I mean, this second score is a measure of behavioral consciousness, and this is how we assess consciousness at the bedside typically. What you could see is this black line is when the psychedelic was administered. The actual diagnosis decreased, and they ended up in a UWS for a period of time, right? After a certain period of time, it then went back up to this MCS minus. We had some new movement of the right leg, but yeah, no new conscious behaviors, right? So one thing that was interesting was the blood pressure increased quite significantly, but after we removed the blindfold, it then it decreased again. So it wasn't like they were sort of disconnected to the environment. They were probably still aware of the environment, because as you remove the blindfold, the blood pressure decreased. So I kind of bring us back to this that I was proposing before, which was maybe, I mean, of course, this is just one patient, right? But maybe what's happening is they have some sort of, that we push the brain dynamics closer to criticality, and they have some sort of increase in awareness. But actually, in order to perform a task, in order to respond to command, you need a segregation of different brain compartments, and that's not possible when you have this massive structural damage. So it's more like scenario 2, perhaps. Okay, so yeah, I'd like to thank all my collaborators and take any questions. Thank you.